Good evening. My name is David Jamieson. I'm the organiser of the July Lectures in Physics program. And on behalf of the School of Physics and the University of Melbourne, I'd like to welcome you to the fourth of our five July Lectures in Physics for 2020 on the theme of physics and life. I'd like to acknowledge the Wurundjeri people, who are the traditional custodians of the land on which the university is built. And I'd like to pay my respect to their elders, both past, present and future, and extend that respect to any other Indigenous Australians present tonight in our audience. Well, tonight's speaker has already had a very prominent role in the media, explaining clearly to us all the issues associated with the present pandemic. Professor James McCaw, James, is a professor of mathematical biology and epidemiology at the University of Melbourne. He actually obtained his PhD in theoretical physics with us in the School of Physics some 15 years ago. But he then moved into the field of infectious disease dynamics. So his work today is at the interface between mathematics, epidemiology, and public health. He collaborates with the Commonwealth Department of Health and Ageing for a long time, since 2006. And his research has helped shape our pandemic response plans that are being implemented today. He's also been an advisor to many international governments overseas to help manage pandemics in their countries. During the COVID-19 crisis, he's worked as a member of the Australian Health Protection Principal Committee to help manage the response. Before I hand over to James, I just wanted to remind the audience that we certainly welcome questions from you, and you'll find a Q&A button at the bottom of the screen, and we'd welcome you to type questions there during the lecture, which we will have an opportunity to answer some of them at the end. So, James, over to you.
Thank you very much, David, for the kind introduction, and I'm really looking forward to being able to talk about how a physicist has found themselves in the middle of responding to a global crisis. And I assume that my slides are up on the screen. I'm sure David will pipe up if it's not there yet. So I couldn't decide on a title for my talk this evening, so I've given it three names. One is the COVID-19 pandemic. Another one is the physics of epidemics, which is clearly something that I'll want to bring up, given this is a July lecture in physics. And the other one is it's the role of mathematical modelling and pandemic in preparedness and response. And just to sort of, I really wanted to make a point about my affiliation. I'm sort of a person who has skills across many different areas, and it's very typical of people who end up working in the area I do. So my primary affiliation is with our University of Melbourne School of Maths and Stats, but I have a long-term relationship with our School of Population and Global Health, where I worked for over a decade, and I also have an honorary appointment at the Peter Doherty Institute. So I kind of spread across many places and have a wonderful opportunity to meet and work with people with very different skill sets. So I wanted to just start by going back 101, 102 years to 1918-19. And before COVID-19 arose, some of you may have been aware that there was a pandemic of influenza about 100 years ago that spread around the world in 9 months. And it killed 40 to 100 million people. It's hard to estimate exactly, but a vast number of people died in a very short period of time. And you've got to remember that the world's population was dramatically smaller back then as well. So this was a catastrophic event that not only had a societal and a clinical impact, but it had a demographic impact as well. It changed the nature of society. It of course came on the back of World War I. But I spent a lot of time studying this epidemic, you can see in the middle of the screen, this is over time, it's the number of deaths per week and you can see it sort of waxes and wanes, and so that dynamic, that tempo, why it goes up and down and up and down. These are called pandemic waves, and I've studied those, and I'll say a little bit about them later on in the context of COVID. So these are now scarily and tragically sort of rather familiar pictures. Influenza pandemics, this was by far the worst pandemic. We had two more in the 20th century and one earlier this century in 2009. But the 1918 pandemic was far, far worse than any of the others. But we're now seeing not dissimilar pictures to this today. And this is both a tragedy and also not really a surprise, because we know for viral diseases, viruses like influenza and now coronaviruses, there's often not a lot of treatment strategies. We have vaccines didn't exist in 1918, and vaccines take months, if not years, to develop now for a novel virus. We don't have antibiotics, they treat bacteria, and we have some antiviral drugs, but they often, virus specific, can take a long time to develop, and they're often not as effective at preventing the infection or getting rid of the infection compared to antibiotics. So that was a pandemic, and the world's been planning and anticipating a pandemic again, and it's most unfortunate that the year 2020 is when it's come. But infectious diseases are much more than pandemics. I've got the pandemic there on the bottom right of your screen, but the real, the most common diseases aren't diseases that spread around the world explosively, but they're there in our everyday life. Most of the time, these are no longer a public health threat because of our excellent vaccination policy and our childhood immunisation strategies. And maths is in there as well, and I'll tell you in a moment about how mathematics informs our policy on vaccination. But on the left here, I've got a picture of cases of measles per 1,000 population in children. I think this data is from the United States. I've had this slide for so long, I've almost forgotten what country this was. I believe it's the United States. And what you can see is that for children, measles, about 50 to 60% of children, newborns every year, got measles all the way through the early 20th century. And then when the vaccine came in the early 1960s, the incidence of measles, so the number of people getting it every year, essentially plummeted and went almost to zero. This is what vaccines can do. They can eliminate a public health threat. And measles is a great success story, but we have in our childhood immunisation strategy in Australia, we vaccinate against almost 20 pathogens, both bacteria and viruses. And that avoids a huge amount of childhood mortality and morbidity. So infectious diseases can look very different. They can look like these sort of consistent endemic infections, and they can be explosive outbreaks like pandemics of, COVID-19, SARS, pandemic influenza, Ebola. And we have mathematical models that help us understand those and help us respond to them. So before a pandemic, people like me worked with government for a very long time to try and help understand how to plan for them. It's a little bit like planning for an earthquake. You know it's going to come, but you don't know exactly what it's going to be like. And every earthquake is different. Every pandemic is different. So you can be prepared, but then once it actually starts, you've always got a real-time, rapid response where things are changing quickly and you need to get information from out in the field back to the decision-making center. So the key questions, and a lot of these questions are sort of obvious in hindsight, but it actually takes a lot of research to get to being able to ask these questions. Things like, well, how transmissible is the pathogen, in this case, COVID-19? And how severe is it? And it turns out that these two things are really the two critical things you need to know about a pandemic virus to know how to guide a response. And you can see this picture I've got on the right. this is a picture that you will find in Australia's COVID-19 response plan, if you look it up on the Commonwealth Government's website. And it's a picture that a member of my team drew in late January or early February when we needed to adapt the response plan for flu, and we had to adapt it to become a COVID response plan. So we took our response plan for pandemic flu, which has all of these, you can see a few boxes with influenza descriptions and years on it, and we whacked an NCOV 2019 big dot box because we didn't know what how transmissible it would be or how severe it would be in early February. And then the other key question we want to ask is, well, how controllable might this virus be? And what do we need to know? How do we measure the transmissibility and the severity? How do we measure those things in real time to be able to make an informed decision about how to respond? So now, in February, we put a big dotted box. We knew it was very contagious, but we didn't really know how severe it was. There wasn't enough data coming out of China at the time. This is where I think it is. It's transmissible. It's quite transmissible, and its severity is on the upper end of anything that we anticipated, and that's why this is such a severe a severe global pandemic, and why the response options we've seen have been unprecedented. You can see over on the left, I've put how controllable might this be, and what we then think about is how far can we shift this red dot. A drug that saves lives might move the dot down, but there aren't really any drugs like that at the moment that we know of. There are some in clinical trials. The other thing, and really the key measure we've had to change the spread of COVID-19 so far, and very successfully in Australia, is we've got interventions that move this dot to the left so that it's less transmissible, it's spreading less in the population. And by spreading less in the population, we avoid sending people to hospital. Of course, there are societal impacts that we all know all so well, having lived through it. And just a side point, isolation, quarantine of contacts, these are interventions that were well understood, well considered. We know how effective they can be. Something that has not been considered in any pandemic plans anywhere in the world, and not in Australia, prior to COVID-19 was the idea of societal lockdowns. We know that they would work, but it was never seen as a plausible or proportionate or reasonable response. There were partial lockdowns 100 years ago, closing cinemas, but we didn't fully shut down society. So the response to COVID-19 has been unprecedented and has been effective, but it's also pushed us beyond where we thought we would ever be. And I think that's something that it's worth reflecting on, that society has responded, decision makers have made difficult decisions in unprecedented times beyond what any of the planning perhaps considered. So that's a little bit of background. What on earth's a physicist doing talking to you about this? So infectious disease dynamics is the area I work in, and it's been around for a long time, but it really came of age when the two men in front of you, Roy Anderson, who's from the UK, and Bob May, who very sadly passed away just a few months ago, and is well known to a number of members of the audience, I'm sure. Bob May is a physicist and trained as a physicist in Sydney before moving into the area of ecology, I guess in the 60s and the 70s. And then went on to have an amazing career at Oxford. I had the pleasure of meeting him there a number of times over the last, earlier on in my career, about a decade ago I last met him. And these two people essentially founded the field of infectious disease dynamics. They brought skills from studying ecological systems, and they brought their mathematical and physics skills to the area that I'm going to talk to you about. And this is the the link. It's an Australian link to the field, and I'm very lucky to have met Bob in particular, who gave so much to the world, really, because he helped everyone understand how mathematics and good physics type thinking can give deep insight into what are very complicated problems to deal with. And a lot of this work, he was very influential in helping understand and respond to the AIDS epidemic of the 80s and 90s. But it goes much further back than that. This is a beautiful front page of a scientific journal article called A Contribution to the Mathematical Theory of Epidemics, published in 1927. And it was published by two physicians. Physicians back then knew their calculus. I won't show any of the details, but this paper is full of beautiful integral equations and lots of limits. And it's a wonderful paper to read. And I'll draw your attention to the bottom two lines here, which gets to the heart of the problem that they were studying. And it gets to the heart of why physicists and people who understand how to apply mathematics to scientific questions are so important here, which is they just asked a question. They said, consider one or more infected persons introduced into a community of individuals who are more or less, fuzzy language, but who are susceptible to the disease in question. And what happens? That's it. That's the question. What happens if we take a group of people who are susceptible, the world, to COVID-19, and we introduce an infectious person who meets with other people and interacts? That's what mathematics of epidemics is all about. But before I dig deeper, I hope when I show you some, a couple of models and some equations, that you are surprised at how much they leave out, how simple essentially they are. Even if the math looks complicated, that the models are simple in terms of what they're capturing. But I hope you can read the slide here, but I want you to think very carefully about what it is that a model gives you. So this is Lewis Carroll's paradox of the complete map. And this also gets to where physicists and physics-like thinking is so valuable. So we all know what a map is. It's a small, simplified representation of the real world. It could be a map of the Melways map of Melbourne. It could be a topographical map that you use to go on a bushwalk. If only we were allowed to do that right now. And so they had their map at 6 inches to the mile. And then they exclaimed, then we tried 100 yards to the mile, and then we came to the grandest idea of all. We actually made a map of the country on the scale of 1 mile to the mile. This is a map that can have all of the detail you need, because it's a model, and it's a model with more detail. It's a model that captures all of the intricacies of either disease spread or of the map. But then, of course, at 1 mile to the mile, have you used the map much? Have you used the model much? No, it has never been spread out yet. The farmers objected. They said it would cover the whole country. And so here is really the key thing about modeling in any system, in climate change, in epidemic modeling, physicists modeling, a system. When we have a complicated system, what we learn by ignoring complexity and just keeping the essence, what we care about the most. Einstein said this indeed, where he said, well, it's attributed, but I'm not actually entirely sure he did say it. Maybe someone who's a better historian of physics can tell me, but a model should be simple, but not too simple. And so the skill that people like me have and our discipline have, and that Bob May and Roy Anderson brought, was to realize where the essence of disease transmission lies, and then to exploit that for understanding. So with that sort of background, what is the key number for disease transmission dynamics? And it's this number that I suspect no one had ever heard of, apart from a few of you 6 or 7 months ago, and many of you may well have heard about now, which is the reproduction number. And so R0 is the expected number of secondary cases produced by an infectious individual given that the population is fully susceptible to infection. And it's actually really easy to think about how you compute this number, as long as you could measure something. It's the number of infections. Imagine that I was infectious and I was in a room full of other people, or everyone. It's the number of infections I will make every day multiplied by the number of days that I am infectious for. For Ebola, the reproduction number is about 2, and it's this little picture over here. We have patient 0 in blue. I'm not sure why they're a smiley face. Maybe they don't know they've got the infection. And each they infect 2 people, and those 2 people each infect another 2 before they are no longer infectious. For Ebola, you are no longer infectious either when you recover, which is obviously what we'd hope, or when you are, well, not even dead, because dead bodies, I'm being a bit blunt here, but it's true, dead bodies were also highly infectious. So actual models for Ebola, you're no longer infectious once you were buried. And we have to account for the difference between someone who had died and someone who had been cremated or buried safely. So for Ebola, on average, someone with Ebola spreads it to 2 other people. And so an epidemic grows like, 1, 2, 4, 8, and so on. For SARS, a coronavirus, the R0's about 4. And so the first person infected 4, and on average, those 4 infected each more 4. And so you get this ridiculously fast growing epidemic. For measles, the reproduction number is about 20. So one person makes 20 and 20 make 400. And that's why measles is such a invasive virus, and one that we struggle to control if it ever pops up anywhere in the world, and why the vaccine is so important. So from this understanding and this picture here, we can actually derive a critically important number in public health. And I should note that COVID-19's reproduction number R0 is about 2.5. It might be, it's definitely more than 2. It could be as high as 4, somewhere around 3, 2.5 to 3. That's if you just let coronavirus spread without trying to do anything about it, which thankfully in Australia we haven't. In places less lucky than Australia, it's very hard to do anything about it because of socioeconomic circumstances, and so the virus will spread very rapidly. So what we can do, this is a classical result in mathematical epidemiology derived by people like Bob May, and known much earlier, I guess. It's the critical vaccination threshold. So I'll just ask you the question. For Ebola, how many people would you have to vaccinate with a perfect vaccine, a vaccine that protects you from the infection? How many people do you have to vaccinate so that the number of cases can't grow? And so the answer is half. So if I vaccinate the person, cover them up with green, then there's one more step. I hope my animations work here. These never occurred. These ones with the yellow cross, they never occur because the otherwise infected person was protected, so they don't pass it on to anyone. And so by vaccinating half the people, we essentially stop the growth of the epidemic, and because of random effects, it will then it will die away, and that's something you can prove rigorously with stochastic epidemic models or things called branching processes. For SARS, I hope people have already figured out what fraction of the people you need to protect. It's, R0 equals 2, vaccinate 50%. For SARS, you have to vaccinate 3 out of every 4 people, and that will break the chain of transmission. You won't see the things that I've crossed out in yellow, and you just get 1 to 1 to 1, and the random variation means that eventually you get a 0 and it goes away. And so for R0 equals 4, you vaccinate 75% of the population. And so you can just sort of see from this for measles, 19 out of 20 people need to be vaccinated, which is 95% of the population. And this is why you read in the public health advice that we need to aim for 95% vaccination coverage in our childhood immunisation program, because measles is the most infectious pathogen that we try and protect children against, and it's R0's about 20, and so 95% should be able to prevent measles from spreading in our community. So there's the maths behind a number that I hope many of you are aware of. And it can be, there's a lot more mathematics and more complicated things here. If, you know, a vaccine's not perfect, a vaccine, there are different things that you need to account for, but this is the essence of it. So I've told you a little bit about where the maths and the physics is already, but I wanted to dig a little bit deeper. So early on in an epidemic, we see this picture back here where people are spreading it, and you get, you know, 1, 2, 4, 8, 16, and so on and so forth. But what happens every time you get more and more infection? People who were susceptible become infectious, and then at some stage they recover, hopefully. And so the number of susceptible people in the population slowly but surely will decline. And so we need to account for that decline in susceptibles to understand the long-term dynamics of an infection. And this is critically important, because otherwise a model would predict that everyone always gets infected. But that's certainly not the case. So the way that we think about this is to go back to that idea of a model being something which keeps the essence of the problem, and it's simple but not too simple. And so we're going to ignore space, we're going to ignore age, we're going to ignore all sorts of other characteristics of humans. We're going to ignore, to start with, how we mix. You know, I know that, you know, I spend more time meeting my friends and or people in my household and then my work colleagues, of course not at the moment. But we're going to ignore all of that structure in society. And we're just going to start by imagining that everyone is mixing at random, just like an ideal gas in a box. Every particle is just bouncing around at random, every particle being every human. And we just bounce into each other. And so some of us are going to be labeled as susceptible. Some of us are going to be labeled as eyes, and that means that we're both infected with the virus and we're infectious. And some of us are recovered or removed. So we may have had the virus before, or maybe we've had a vaccine and that protects us, so we're arms. And that's the only thing we're going to worry about. And it's amazing how that simple model is both mathematically still quite tricky, but also performs incredibly well at helping understand how diseases spread. So how do we calculate the number of new infections? If this was at what our population looked like at the moment, it's got, I don't know, quite a lot of S's, quite a few number of I's, and a few recovered people in it. How do we know tomorrow how many I's there will be? So what we need to think about is, how do we calculate the number of new infections? How do we figure out if the person sneezing, it's a wonderful photo. This is why we should wear masks, as the people in the photo in Melbourne below will show you. They're photos from the last few days. If you're infectious, how many people will you spread the virus to? And if you're susceptible, you know, how likely are you to get it? And they're the sort of two questions we want to ask to get to an intuitive understanding of the mathematics that underpins all of the work that people like me do. So what I want you to think about is, imagine that you are infectious. You know, you've had flu, you've had the common cold. Hopefully you don't have coronavirus, of course. But imagine you have some virus. Imagine you're infectious. What factors are going to contribute to, you know, to how many people you will spread the virus to? And the thing that should become clear is that, if you think about this question for a while, is that it's something about how many people you meet, and how likely you are to spread the virus onto them when you meet them. And of the people you meet, the only people you'll spread it to are those who are susceptible. And so from an individual infectious person's perspective, the more susceptible people in the population, the more likely you are to spread it. So the number of new infections will go up with the number of susceptible people in the population, which, once I've said it, should be quite obvious. Now imagine that you're susceptible. If you're susceptible, what would make you worried? It would be that there are more and more infectious people around. because every infectious person has a chance of, if you randomly meeting people, you meet more people, more of them are infectious. If you meet more infectious people, you're more likely to be infected. And so it's the product of the number of S's and the number of I's together, which will determine the number of new infections that occur at any given time. And this is something called a nonlinear term in a dynamical system, because we want to know how the number of susceptibles, the number of infectious, and the number of recovered people changes through time. But one of those terms depends on the product of two of them. And that's what makes, for those of you who have studied your maths, you'll know that's what makes the equations complicated and difficult to work with. There's this nonlinear term. So what we're going to do, we're not going to think about lots and lots of S's, I's, and R's. We're just going to count the total number of susceptibles, the total number of infectious people, and the total number of recovered people. And then we're going to abstract a bit more. And people can move from S to I, and that's called an infection. And people can move from I to R, and that's called a recovery. And we'll just ask a question, well, the increase in the number of infectives is going to be proportional to the number of infectives times the number of susceptibles. And the decrease in the number of infectives is going to be proportional to the number of infectives. If there's more people who are infectious today, more people will be able to recover, because everyone is infectious for a finite period of time. For COVID, it's somewhere around a week. And so if there's more people who have the virus right now, we'll see more recoveries as well. Unfortunately, these disease models are all about transmission. And so a death is the same as a recovery in a model. Even for COVID, more people recover than don't. It's incredibly severe disease. The majority of people do recover though. So that recovery is in no longer infectious person. And this is enough to write down something that we call a differential equation. These are the bread and butter of physics and studying, using mathematics to describe natural phenomena. And that's the physics of all of this, which is that physicists are scientists who know how to use mathematics to study a problem, and infectious diseases is an area where mathematics really comes to the fore to help understand why and how those diseases spread. So I'm going to chuck up some equations for those of you who like them. I don't really expect the audience to all follow along. But these equations tell us about the rate of change of the number of susceptibles, and the rate of change in the middle of the number of infectious people, and the rate of change on the right of the number of recovered people. And you can see there's this term beta times I times S. That I times S is that intuitively, it's that argument about people mixing at random, and you'll get more infections if there's lots of I's and lots of S's together. If there's lots of infectious people but no susceptibles, you don't get any new infections. If there's lots of susceptible people and there's no infectious people, which is the elimination strategy, then also you don't get any new infections. And that I'll come back to that in a moment in the context of our actual epidemics. So these equations here are called the SIR model. Kermack and McKendrick in that paper in 1927 wrote down a more general version of this this model. It's for those of you interested, it's a beautiful paper, as I said before, where this is a special case. And the thing about these equations is we can simulate them on a computer, but no one has discovered a solution to them as yet. And I kind of suspect there isn't one. People have been looking at them for a long time now. But I'll never say that there's no solution, only that no one has yet discovered one for S, I, and R as a function of time. But I can compute them. I've deliberately done this in Excel. I never use Excel for my scientific work, but I think it's an excellent tool to help people understand. I have spent time trying to explain this SIR model to year 9 and 10 students, and Excel is something they know how to use. And it's something that can let you simulate these equations and really understand how the system's behaving. So it's an incredibly useful pedagogical tool. And this is what an epidemic looks like. This is a simulation with a reproduction number of 2. and a population with 10,000 people in it, where 9,999 started susceptible, and there was one infectious person in red. And you see an epidemic grows and then it dies away. And the fascinating thing is that the number of recovered people at the end is it's about 60%. And there's lots of people who are left at the end of the epidemic still susceptible. So a disease doesn't get to everyone, even when it looks like it's doubling all the time. And that's because the S's run out. So just what I want to go on to is, so how big will an epidemic be? In this epidemic, it got up to about 60% of the population. And you can see that here at the reproduction number of 2, it's at about 60% or so. I think this here must have a reproduction number a little bit under 2. So the reproduction number of COVID-19 is about 2.5 to 3. And what that says is that if we let this virus spread, just absolutely let it go and did nothing, which would be a disaster, it infects 70, 80, 90% of the population, if not more. The numbers might not always be exactly what comes from this solution here, which is actually the solution to a linear differential equation. It's a great question to set on a first-year maths exam. That number of people is what COVID-19 would infect if we couldn't control it. It's a huge number. That's 20 million or so Australians infected, and at the moment we've got 10,000. We can't let that happen, and we've got public health responses that won't let that happen. So, modelling for preparedness. This is something I've been working in for a long time. I'm not an author on this paper from 2007. That's my brother there, C.T. McCaw, but some very close colleagues of mine. And what we were doing was talking about the role of models to prepare for influenza pandemics. We've done work on Ebola. I am an author on this paper, somewhere in there. This was when Ebola outbreak, we looked at a risk assessment for the probability of Ebola being transmitted into the Asia Pacific region and then establishing itself. It was a real possibility. Thankfully, it didn't happen. And most recently, this was published around the same time as COVID, but the work was done last year, so well before we knew anything about it. It was in a journal called PLOS Medicine, which is a medical journal, where we were talking about pandemic planning and decision analysis, which is a fancy word for mathematical modelling. So we have adaptable plans for response. We've had an Australian health management plan for pandemic influenza, which I helped contribute a lot of the underlying science to, and it turned into, overnight in February, the COVID-19 response plan. And some of you may have seen this. This is the scenario modelling work that my group contributed before there was a handful of cases in Australia at the time that we did this work. So what we had to do was scenarios. We didn't know what the virus looked like. We didn't know how transmissible necessarily or how severe it was, but we had to put in some planning. It's like climate change planning. We can't wait for it to happen. We need to get ahead of it and plan for it. Thankfully, the relationship between science and policy in public health at the moment, for this at least, is much simpler than the other issue I just mentioned. So this is the y-axis here is ICU bed demand. It's also just a massive epidemic. And what we looked at here was that if we could quarantine and isolate people, we'd get the reproduction number from 2.5 to 1.7. That would give us still millions of cases, but it would be a lot better. And social distancing, and there we only considered in February a 33% reduction in people's mixing. We know we achieved a 90% reduction, which is why the first wave was suppressed or fully stopped. But if we'd only been able to achieve 33% reduction, then we would have had the flattening of the curve, and that would have been millions and millions of infections in Australia by now. And that one of the things I am most proud of from an Australian community response, but also a policy response, is that never occurred. It hasn't yet occurred, and I don't believe it will. So what actually happened? Because none of this happened, thankfully, because we responded much, much more strongly than, and it was anticipated we could, and that's a good thing. So This is a slide that I presented back in mid-April, and I haven't changed the text on the right. So this is up to mid-April. So we control the epidemic. Very few locally acquired cases. Our first wave in Australia was a wave of importations. Very few transmission events within Australia. And I wrote, it's the second dot point on the right here, the population remains largely susceptible. That's an understatement. 99.999% of the Australian population were still susceptible around May to the virus. And so we know from our basic SIR models that then if we start mixing again and the virus is reseeded into the community, it will spread just as if, you know, everyone's susceptible, it will spread as usual. So, and most unfortunately, and it's really very sad to be able to be here and say this, because I was, 3 weeks, 4 weeks ago, we were hoping we wouldn't be here, but it was reseeded. The virus was effectively eliminated from Australia, almost certainly, but maybe it was a tiny bit left. It was reseeded. We'd relaxed. We'd started going back somewhat towards normal, but thankfully not completely. And the virus can spread, and so we now have a second wave. It's a very different wave. You can see it in the colours here. The unknown origin is just an issue with the reporting systems. They are locally acquired cases. And you can see that where it was an overseas acquired wave 1, it's a local transmission wave 2, and that makes it much harder to control. And that's why right now, Australia's at a tipping point. I don't want to go too dark, but that's where we are. So I've told you about R0, but I want to tell you about R effective. And this is a number you may have heard about in the media a bit as well. And that is how many people does an infectious person infect today on average. So here's a plot. These are our latest analyses. These are from 3 days ago, I think. Yeah, 3 or 4 days ago. The 19th of July, I think we produced this plot for the Australian government. This is the effective reproduction number in Victoria since March. And so you can see in March, it was well over 1, and that was the growing epidemic of locally acquired infections that you can see through February and March. And the 3 vertical bars are the timing of the key interventions of the first lockdown. The second, not sure you can see my cursor, but the second wobble of the reproduction number being above 1, which means that, that you'd get a growth of epidemic. That's the meatworks outbreak. And we could detect that in real time. We picked up the Tasmanian Northwest cluster as well as an early warning, and that fed into the policy response. And the second wave in Victoria is this enormous increase in the reproduction number up to almost 2 starting in mid-June. There's some really good news in here though, and it's very hard to understand this from the way that, without the processing of from the models. But that reproduction number has been dropping very steadily for a month. Now, it's still above 1, which means that the number of cases tomorrow will be more than the number of cases today. That may have changed in the last 2 days. We've been great news today. But if that reproduction number had plateaued at around 1.8 or almost 2, then there'd be literally thousands and thousands of new cases right now and every day. But we can see that number is declining. It's above 1, so the number of cases every day is more than the number of cases yesterday, up to stochastic fluctuations. But it's a slower growth than an R of a natural R, and that's because of the successful public health response so far in Victoria. It isn't enough. Victorians need to isolate more to spread the virus less, stay at home when you get a test. All of those things are critically important, but we're on track to get this under control. So just like a weather forecast, we also produce epidemic forecasts, and I'm going to wrap up in a few minutes. I'm aware of the time. So this is the latest forecast of what we believe the epidemic might do in Victoria. And it's my scientific opinion that we're very unsure about what will happen. And that's actually a powerful message. It says that this is on the edge. When we hear people in the media, our politicians and chief health officers talk about this being on a knife edge, a lot of that directly from figures like this that me and my team present to them. the case data at the moment and the reproduction number are consistent with a declining epidemic over the next 3 or 4 weeks, with new cases right down to the tens. They're also consistent with a further escalation of epidemic activity. And it's up to every Victorian and every Australian to behave in a way that pushes it down, not up. I hope it's an incredibly serious point there as well. I've got one more slide, which is New South Wales. New South Wales is also on a knife edge at the moment, because people in New South Wales are mixing more. They're spending more time out and about. They're slightly less compliant with measures like the 1.5 metre rule. And so the effective reproduction number in New South Wales is actually higher than in Victoria. Of course, in New South Wales, there's fewer cases, which means the public health response is more able to keep up, which is another key critical part of the response. But New South Wales has a very high chance of seeing a significant escalation of epidemic activity over the coming month. When this lecture is replayed in August, it will be very interesting. I feel compelled to say this because it's so timely. We'll wait and see if these forecasts were reasonable or not. And for this one, I desperately hope that I'm wrong. Well, not wrong, but that these don't account for any response measures that may well be put in place shortly. So I just wanted one more slide. Mathematics and models, I hope I've shown you how important they are to understand an epidemic, but models don't make decisions. Humans make decisions. And this is a photograph. I'm in it. You can see my nose. I'm in the bottom left. The person at the front left is Jodie McVernon, who is my very close colleague and leader of Australia's mathematical modelling response. Just above me to my left shoulder is Brendan Murphy, the Chief Medical Officer of Australia. And other members around the table are all of the states and territories' chief health officers. This is a photograph from just before the first lockdown, and it was the last face-to-face meeting I had. This is the Australian Health Protection Principal Committee. This is how decisions are made. The models are there. We use them. Public health experts advise these groups. People like me and others are there. But this is how decisions are made, and models are one part of that process. So that's Australia's response in a nutshell on the slide in front of you. And those people are in the front of the media, but they're every day we meet. We meet 7 days a week and have since January to understand what's going on and try and do everything we can to protect Australians. So mathematical models, which is the physicist's expertise, they help us understand the how and the why of infections, how they spread through populations. They help us plan for future events, and they help us respond to the situation. And they inform decisions, but they don't make them. And those decisions are made by a skilled group of committed individuals who look at all of the evidence in front of them. And with that, I'd like to say thank you very much. It was an absolute pleasure to be able to present in the July lectures in physics. So thank you.
It's remarkable how little stands between us and a catastrophe. And it's wonderful to see the role of your mathematical models in helping the decision makers come up with the strategies for keeping us safe. It's really frightening to see some of those forward projections and how little a change in the R value can lead to a catastrophe. So, this is all that's standing between us and some of those dismal scenarios. We have actually a large number of questions, and so we're not going to be able to get through them all. They're very good questions, but we have recorded all of these questions, and we will add answers to them when we rebroadcast tonight's lecture in August. But I think for tonight, I'll just select some of the questions for you, James, if we can go through them. So the first one is from Kevin Korb. It's quite a long question here, but I might just paraphrase it. The question basically goes at wanting to know why an elimination strategy is being ruled out by the National Cabinet, if indeed they have, versus just settling on a suppression strategy. Is their decision-making process...
It's a great question.
Yeah. So is the decision-making based on science or politics?
It's based on science and a whole balancing of things. So it's an excellent question. And the suppression strategy has as a goal, and it was articulated well before it was enacted, that we would hope, we weren't sure if we'd be able to achieve the successes that we had across April and May. And we did under that strategy. And it was always hoped that we would actually achieve elimination. It's elimination of the virus. The issue with calling something an elimination strategy is that it is perceived, and I strongly believe this, it's perceived as an elimination of threat, which it is certainly not. There is a global pandemic, and the threat will remain. And indeed, Victoria has shown we've got a second wave, which has come almost certainly from a breakdown in one event in the hotel quarantine system. So it started again. So this was, no one really knows if Victoria genuinely eliminated the virus. If we'd had another few weeks of without the reintroduction, we may well have it. That will probably be lost to history. We'll never know. So the strategy that's being taken forward is actually the same one, which is we want to get the virus as low as possible. If we can eliminate it, that is wonderful. That is actually desirable, but it's not elimination of the threat. And so I've always actually had quite an issue with the use of the term, not because it's a very difficult one to then get the communication strategy on correctly. So it's suppression in a way that allows the society to understand that they have a long-term need to change their behaviour. And I don't think the word elimination gets us to that. So it's perhaps actually almost down to semantics, but it's not an overtly political decision. I think it's a rational scientific one. But it's a controversial one. Not everyone's going to agree with me.
Yes, okay. Another question here from Justin Middleton. Why are European countries allowing their citizens to resume flying overseas when those countries still have an infection rate higher than in Australia? What model are they using? Yeah,
look, I don't know. I think Australia and New Zealand, we've the number of cases we've got, even in Victoria now, are so far below what we've seen tragically in the United States and Europe. I'm here, my mind is very much in the Australian context. It's very hard to know what it must be like to work in that policy environment in Europe. So I don't really have a good answer. It feels incommensurate, I agree, with how Australia is responding. Australia's responding decisively because we've seen the success. It's almost a bit like the first question. We know that we can avoid it. We know what the consequences we can see in Europe. But once the disease is at the level it is over there, it's very hard to know what that would be like to live through. And so I don't want to judge anything, but it's not compatible with getting rid of the virus. There's no contemplation of elimination in most of the rest of the world.
Okay, we have one of our audience, Charlie Sherney, has asked a large number of questions here, which are all very pertinent, but I'll just put one to you from Charlie's portfolio of questions. The others will come through later after we finish. But it overlaps with a question also from Martin Sevier. Martin comments that in one of your early graphs there showing the other viral pandemics, that COVID-19 actually appeared to be less infectious than SARS 2002. And Charlie Sherney's question is, The data recorded, he believes the data recorded for the year 1999 had 4 million people die of the flu worldwide. How do you view corona today compared to the assessments of 1999? So these two questions both are asking you to assess where COVID-19 fits in the historical record.
Yeah, right. So SARS had a higher reproduction number, but the key difference for SARS is that people showed symptoms before they became infectious. And so we were able to manipulate that red dot, the transmissibility of SARS, much more easily than we can for the coronavirus. And so, and I think with SARS, we were lucky. It almost got away from us, and that would have been something, well, the world would have been a different place 20 years ago. So SARS was more controllable. We could manipulate the transmissibility more easily by getting people who showed symptoms to isolate, and they would then not spread it. Coronavirus is, in that sense, much more like influenza. People are spreading the virus before they have symptoms. And so the quarantine and isolation strategy, which is it's still helpful because it reduces the infectiousness, but it doesn't eliminate, I shouldn't use it, it doesn't prevent all of that infection. And so this is just fundamentally a harder virus to control, even though its reproduction number is lower. Flu is the same. In terms of influenza deaths, these things are not comparable. I'm not aware directly of that 4 million in 1999. There have been some particularly bad influenza years over the time. But the coronavirus, if it infected, 70% of the world's population and killed 1% of them, that's a much, much bigger number.
Okay, I've got a question here from Sandy Dance about this other R coefficient, RF, R effective. Can you just say a few more words about how R effective is calculated and how it differs from R naught?
Yeah.
And in particular, what inputs do you use? Is Google tracking of traffic and people involved?
Yeah. So when there's an active epidemic, excellent question. When there's an active epidemic, and there's lots of cases, there's some beautiful statistical methods to estimate R effective. Essentially, what we do is we look at the number of new cases on a day. And by new cases, I don't mean the headline report. I mean, you would have to infer when people were infected. So you have to look at the symptom onset date and then map back from there to when they were likely infected. And so any day when you say, well, the number of people who got infected today was a certain number, which is something you can read off the data set, then you look back through time and you say how many people were there around who could have infected them. And that lets you estimate the reproduction number that day. And then you move on a day ahead and you say the number of people who were got infected today is, 17 or 4,006 or whatever the number is. And you look back through time and say the people who could have infected them were this many. And so you can estimate the reproduction number through time. And then there's all sorts of complicated statistics in there because there's biases, there's missing data, there's all sorts of subtleties. Which makes it a hard mathematical and statistical problem, but that's how you work it out.
Okay, so maybe I'll just finish with one final question here from John McDonald. A question about, I guess, a more fine-grained approach to R naught. How would you expect R naught to change as the number of susceptible people changes? And he says, I would expect that the more connected people would be more likely to be infected early, and that the proportion of hermits and introverts in ETS would increase over time. And this, how would this affect R naught?
Yeah, so and I forgot to answer the other part of the question about how, from the previous one, about how Google mobility data and all of those things fit in. That all manipulates what the reproduction number is as well. And if you're interested, we just published a technical report on the Doherty Institute website that goes into a lot of detail on how we use that sort of data to estimate reproduction numbers. There's lots of lovely statistics and mathematics in there. It's a public report. On this question about the number of susceptibles, absolutely. So at the peak of the reason an epidemic reaches its peak, if we ignore interventions and just let an epidemic run its course, which is what has normally happened with viruses. We don't try and change their behavior typically, we just let them spread. The common cold, for example. The epidemic peaks because the number of susceptibles has dropped to precisely 1 on R0, because then it's just like the vaccine. Then the infectious person, instead of infecting, say, 2, they infect only 1, and that's the turning point of the epidemic. So it's when the rate of change of the new infections, or the number of infections, sorry, the rate of change of that equals 0. So you can do that from the mathematics. The second part of the question about network structure, it's very much like the model I showed you, SIR, is like the ideal gas. Everything's just bouncing into each other. But of course, there are the ideal gas equation is an approximation, and there are better models that account for the walls and, you know, all of the other things that they do. And that's the same in epidemics. So we can study the transmission of epidemics on networks, where it is absolutely true, people who are higher degree nodes, people who've got more social interactions, both get the virus earlier and spread it to more people. And so that is it's a subtlety, it's an effect which you can, it's very hard to pick it up in raw data, but we know it's there because we know that we don't mix randomly. We have repeated contacts, we have structure, we have households and schools and workplaces, and there's lots of mathematics and computational epidemic models on networks. It's and actually one of the world leaders is in Melbourne. He's Dr. Joel Miller. He's at La Trobe, but he's one of the key people who wrote an influential book on this a year or two ago.
It's great that we have that depth of expertise. So I'd just like to then end to thank the audience very much. I have one final comment I'd like to read out from Liz Merkovich. Thank you, James. Love it that maths matters. I can only agree with that comment. So thank you again for a very informative and sobering lecture tonight. And it's good to see physics in the service of keeping us healthy.
Thanks, David. And please, public service announcement, please keep your distance, stay at home, wear a mask in public. If you get tested early, and stay at home while you're waiting for the results.
Thank you very much for coming, and stay safe.